deviates from the normal menstrual parameters, namely frequency, regularity, duration of the bleeding and amount of bleeding. These four are the normal parameters for menstruation. So, normal frequency is 24 to 38 days. If menstruation occur outside this frequency, that is, if it occurs less than 24 hours, 24 days, it is called frequent bleeding or epimenorrhea or polymenorrhea. And if the frequency is more than 38 days, in that case it is called infrequent bleeding or oligomenorrhea. Then comes the regularity. Regularity of the cycle. When we consider regularity of the cycle, actually what we do, we look at last 12 months of menstruation. In 1 year calendar, if the regularity of the cycle is within 7 to 9 days, or that cycle variability is not more than 7 to 9 days, it is a regular cycle. It is said that her cycles are regular. Number 2, duration. Normal duration is 2 to 8 days. If it is more than 8 days, it is called prolonged period, and if it is less than 3 days, it is called shortened period. And finally, the volume of blood loss. You all know average blood loss is 35 to 40 ml. Physiological range is from 5 to 80 ml. If it is more than 80 ml, it is called heavy menstruation, and if it is less than 5 ml, it is called light menstruation. So before understanding light menstruation, come. So if it is before going to AUB, you should know that these are the normal parameters, and any deviation outside these parameters is called abnormal bleeding. Previously, various nomenclatures were used depending on the age, considering the age of the patient, physiological status of the patient, cyclicity, duration, etc. So, in 2011, FIGO abandoned all these nomenclatures, and all types of menstrual bleeding previously known as menorrhagia, menometrorrhagia, polymenorrhea, epimenorrhea, postmenopausal bleeding, postcoital bleeding, puberty menorrhagia, all these terms are abandoned now, and all these types of bleedings are grouped under 2 headings. One is heavy menstrual bleeding, the other is intermenstrual bleeding. So, here all previous nomenclatures are abandoned now. All types of bleedings are included under these 2 headings. Number 1, heavy menstrual bleeding. Heavy menstrual bleeding means excessive bleeding in amount or duration so as to incapacitate her in her daily day-to-day activities. Important causes are leiomyoma, endometrial hyperplasia, endometrioma, endometriosis, DUB, chronic PID, etc. These are the causes of heavy menstrual bleeding. So, heavy menstrual bleeding is excessive bleeding in amount and or duration so as to incapacitate her day-to-day activities. The intermenstrual bleeding, any bleeding which is acyclic and irregular is called intermenstrual bleeding. So, these are the 2 main terms used recently. In the causes of intermenstrual bleeding are fibroid polyp, endometrial polyp, cervical cancer, endometrial cancer, IUCD, etc. Palm coin classification. As I already said that there are earlier various terms were used to signify different types of bleedings, but definitely there was no consistency in the nomenclature. As I said, some bleeding were classified as according to age of the patient, puberty menorrhagia, और कुछ उसमें there is nothing as that she is around age of puberty, that's why that is called puberty menorrhagia. considering her age. In physiological status, whether she is menstruating or not, whether she has gone to menopause, that is post-menstrual bleeding. Again, that is considering age, physiological status, sometimes considering her intake of pills, breakthrough bleeding, withdrawal bleeding, etc. So, to bring a consistency in that nomenclature and proper classification system, FIGO introduced this classification in 2011. Why this was necessary? Because to facilitate communications, number 2, to provide proper clinical care, and number 3, fostering a common language for research work. These 3 are the motto of this newer classification, that is palm-coin classification, which was introduced by FIGO in the year 2011. What is this? Palm-coin, this is an acronym and it has got 2 parts. First one is PALM, P-A-L-M, PALM. This is also called the structural group. Why it is so called? Because in this group there is some structural abnormality in the genital organs, which can be seen visually or by some imaging techniques or histopathology. So in this group you will find a definite pathology in the genital system. That's why this group is called structural group. And the other one is non-structural group. Here you cannot diagnose the entities by examining visually or by imaging techniques or histopathology. So these are that's why this is called non-structural, and the first one is structural. So in the structural group, as you get from the acronym PALM, first one is P. P for polyp. P for polyp. Polyp may occur in the endocervix, in the endometrium. In the endometrium, it may be of 2 types, fibroid polyp or endometrial polyp. What is a polyp? Endometrial polyp, fibroid polyp, we all know when a submucous fibroid grows towards the cavity, its false capsule when ruptures, it is called polyp. So long as the capsule is intact, it is a submucous fibroid. As soon as the capsule ruptures, it becomes fibroid polyp. And what is endometrial polyp? Endometrial polyp, localized endometrial growth. It is a localized endometrial growth, probably due to some localized enhanced aromatase activity. Aromatase, you all know, is an enzyme which converts androgens to estrogens. So this locally increased aromatase activity and probably some gene mutation, these are the causes of endometrial polyp. Number 2, AUB-A. A means adenomyosis. This is a type of endometriosis where the endometrium invades the uterine musculature. Adenomyosis. Number 3 is AUB-L, that is leiomyoma. Leiomyoma means fibromyoma or fibroid, commonly called. Fibroid, there are various types. To start with, all fibroids are intramural, but depending on the direction of growth, whether it grows outwards, then it becomes serous, and if it grows inwards, it becomes submucous. Depending on the size of the fibroid, depending on the numbers and location, the symptoms of bleeding occur according to the size, according to the number of fibroids. So if a fibroid goes outwards, that is, if it becomes subserous, there will not much menstrual disturbance. But if it remains intramural, uterus as a whole will increase, it will affect the uterine contraction, so hemostasis will be hampered. Intramural fibroid will result in HMB, heavy menstrual bleeding. But if it grows towards the cavity, that is, if it becomes submucous, even a small size of fibroid can cause intermenstrual bleeding. So the symptoms of bleeding symptoms of fibroid depend on number, size and site. Last is M. AUB M is malignancy or hyperplasia. Causes are, as for example, CIN, cervical intraepithelial neoplasia, endometrial intraepithelial neoplasia, endometrial hyperplasia, endometrial and cervical carcinoma. These are the malignancy and hyperplasia. So what is the difference between polyp and hyperplasia? Hyperplasia, in hyperplasia, the whole endometrium as a whole is hyperplastic. It commonly occurs due to unopposed estrogenic activity. And in polyp, there is a localized hyperplasia of the endometrium. These are the difference between hyperplasia and polyp. Then the non-structural group, that is Cohen group. Cohen C for coagulopathies. Coagulopathies causes are von Willebrand disease, number 2 thrombocytopenia, leukemia, and we all know that hemophilia rarely occurs in females, in women, but hemophilia can occur in women. So rarely hemophilia may be another cause of coagulopathic disorder. What is this one is most important, von Willebrand disease. Some bleeding diathesis actually patient comes with menorrhagia without any other symptom. Von Willebrand disease is an autosomal dominant disease due to deficiency of a factor known as von Willebrand factor. It promotes platelet aggregation and prevents fibrinolysis. So its deficiency leads to less platelet aggregation and it promotes fibrinolysis. That's why it causes, that's how it causes menorrhagia. Then comes O, ovulatory dysfunction. Ovulatory, this was previously called DUB, dysfunctional uterine bleeding. So this term is now not used at all. So in that, instead of that, this is used AUBO or ovulatory dysfunction. In 80% cases, it is anovulatory, and in 20% cases, it is ovulatory. Or the cycle is anovulatory or anovulatory. Anovulatory cycles commonly occurs in the extremes of reproductive age. That is around the age of puberty and around the age of menopause. So this type of bleeding occurs in the extremes of reproductive age, and ovulatory usually in the reproductive age group. The difference in these two is when there is ovulation, there is progesterone, and when there is no ovulation, there is no progesterone. So progesterone is a growth limiting hormone. It limits the growth of endometrium. So when there is no progesterone, unopposed estrogen outgrows the endometrium. So when the bleeding starts, that usually becomes very heavy. Then comes E. E is endometrial cause, endometritis, hyperplasia, atrophy, excess production of vasodilator prostaglandins. We will come to this later. You know, some prostaglandins are vasodilators and some prostaglandins are vasoconstrictors. When this balance is disturbed, there is abnormal bleeding. Then comes AUB-C. Oh, এটা তো হয়ে গেল. Then AUB-I, that is iatrogenic. Iatrogenic means caused by the physician. What are the causes? Various hormonal preparations, what we use for contraception, for treating, or for HRT, hormonal replacement therapy. So various hormonal preparations, insertion of some contraceptive devices, certain drugs that causes hyperprolactinemia, and namely phenothiazis group, metclopramide, ranitidine, domperidone is a very common group. Hyperprolactinemia is very common with domperidone. Often people used to take domperidone continuously without prescription and ended up with hyperprolactinemia, amenorrhea, very common nowadays in OPD patients. Then come AUB-N, that is non-classified. Even after this, some diseases are there, we cannot put them in any group. These are PID, pelvic inflammatory disease, TB, tuberculosis of the endometrium, Asherman syndrome. Asherman syndrome is synechia of the anterior and posterior wall, that is called Asherman syndrome. Usually occurs after vigorous curettage or repeated DNC or tubercular endometriosis. When the endometrium is damaged, the anterior and posterior wall becomes fused. This is called synechia of uterus or Asherman syndrome. Some foreign bodies typically seen in young patients. Sometimes those who are psychologically imbalanced, they also put foreign bodies inside vagina. And arteriovenous malformation, Mullerian abnormalities like uterus didelphys, bichordate uterus, septate and septate uterus. This is the group still non-classified. So Palm-Cohen, why this classification was necessary? Because before this there was no systemic classification. There was a region of inconsistency. So to put all this classification actually etiology based. No other factor is considered. Palm-Cohen classification is typically etiologically based. Considered etiology, this classification is done. No other factor is considered here. Now, why AUB, abnormal bleeding, why occurs? To know why abnormal bleeding occurs, you have to know the normal hemostatic mechanism of normal menstruation. How menstrual bleeding stops in a normal menstruation. Number one, as you all know, the functional layer of endometrium grows under the influence of estrogen and progesterone, and that upper part is fed. So the spiral arteries are open-ended and they start bleeding. So that open-ended arterial open ends are blocked by platelet aggregation, platelet plug and fibrin. They block the open end of the arterioles. So if this is hampered by any method, there will be menorrhagia. Number two, localized vasoconstriction. As I was telling earlier, PGF2 alpha and thromboxane A2, these two are strong vasoconstrictors, and PGE2 and PGI, that is prostacyclins, these are vasodilators. If this balance is altered, so there will be abnormal bleeding. Normally, estrogen produces both this PGF2 alpha and PGE2 produces both these prostaglandins in 1:1 ratio. But progesterone induces prostaglandin PGF2 alpha twice as much as PGE. So progesterone is more vasoconstrictor than estrogen. Number three, myometrial contraction. Uterine contraction. Myometrium is the muscles of the uterus that has some role in controlling the amount of bleeding. If there is a large fibroid or in adenomyosis, myometrial activity is hampered. Myometrial contraction is hampered and that causes menorrhagia. Number four, regeneration of endometrium. Endometrial regeneration is a very important point. Even before the shedding is complete, that is from day 2 to 3 onwards, regeneration starts. Before completion of menstrual shedding, regeneration starts side by side. So if there is any difficulty in regeneration, that is if there is low level of estrogen, bleeding will be much more. Number four, locally produced endothelin and platelet activating factor. These two are also very good hemostatic factors, vasoconstrictors. So if they are also disturbed, then it will result in abnormal bleeding. So these are the normal mechanisms of control of bleeding in normal menstruation. If any or all of these factors are altered, it will result in abnormal uterine bleeding. Now, how will you approach to a case of AUB? First, confirm the menstrual abnormality. Some patients come and say, sir, I have got irregular period, I am having periods 2 times a month, 3 times a month. But if you take the history critically, you will say that she is absolutely normal. What is your problem? Sir, I am having 2 periods in a month. So, according to the normal menstrual parameters, you see, if a woman menstruates on the 2nd of particular month and again on 25th or 26th day, that is absolutely normal. But she will consider it is abnormal because I am having 2 menstruations in a month. So, first approach is correct history. You have to ask the patient, you maintain a menstrual calendar at least for 3 months. Then you will be able to notice that whether she is actually having irregular menstruation or not. Many patients get unnecessary treatment on hearing her history. Just she is saying I am having abnormal bleeding, you prescribe some medicine. That is not right. So first is confirm the abnormality, whether she is actually having or not any abnormality. Number 2, you have to diagnose whether there is any pelvic pathology. DUB, as it was previously defined in this way, that dysfunctional uterine bleeding is a bleeding where you cannot get any pelvic palpable pathology. That was a disease by exclusion, where you don't find any cause of bleeding. That was designated as DUB. So, you in some cases you will get some pathology as we have already discussed, like fibromyalgia, polyp, endometriosis, some pathology. So look for some pathology or some iatrogenic or systemic. Iatrogenic has been said whether she is having irregular contraceptive pill or using any intrauterine contraceptive device or taking some anticoagulant drugs, or any systemic cause like thyroid, both hypothyroid and hyperthyroid both causes menorrhagia, and chronic liver or kidney disease can cause abnormal bleeding. Then formulate a definite therapy protocol according to pathology. So these are the 3 modes how we will approach to a case of AUB. History and physical examination. As already mentioned, details of history regarding duration, amount, frequency and type of bleeding, that is whether it is frequent or infrequent or prolonged or heavy bleeding or intermenstrual bleeding. History. Number 2, history of hormonal preparations, IUCD, anticoagulant drugs, whether she is taking any of these. Number 3, history of bleeding diathesis in her families, because you know these diseases, hemophilia, von Willebrand disease, these are genetic disorders. Usually patient have 1 or more relatives suffering from this type of disease, or if she has epistaxis, particularly more than once in a month, bleeding gums, excessive bleeding from injury site, accidental cut, bleeding is not stopping. From this history, we have to think of some bleeding diathesis. Number 4, menstrual calendar. Importance of menstrual calendar I just explained. This is the importance because some patients do not know what is regular, what is irregular. Number 5, assessment of blood loss. Whether patient is saying, sir, I am having heavy bleeding. You on examinations saw that her hemoglobin is 12 plus, etc. So you have to assess whether she is really suffering from a heavy loss. So how do you assess blood loss? Normally, apart from pathological or blood examination, clinically from history, what we inquire about is how many pads she is using in a particular menstruation cycle. If total number of pads in a particular cycle is more than 21, then she is having menstrual bleeding. Number 2, if she changes pad every 3 hours or less period of time, she is having heavy menstruation. If she passes clot, normally you know menstrual blood does not clot, but if she passes clot more than 1 inch in size, she is suffering from heavy menstrual loss. So from clinical history, we will inquire about these few points, whether she is really having or not. Number 4, on examination, pallor, edema, whether thyroid is enlarged or any neck glands palpable, and systemic examination. Number 4, speculum examination and bimanual examination to rule out any local pelvic pathology, and as you all know, we cannot go for bimanual examination in unmarried women. So in that case, rectal examination in virgins should be done. Investigations. What are the investigations we undertake? Number one, blood for hemoglobin, hematocrit, TCDC, ESR, platelet count, peripheral blood smear, coagulation profile, thyroid profile, and prolactin. These are the common tests. FSH, LHR is usually not included in AUB, sorry. Number two, von Willebrand factor, as already been said. Then ultrasonographic examination, USG, you all know USG is done transabdominal, transvaginal, transperineal, transrectal. According to situation, it is done. So in gynecology, and if she is a parasoman, TVS is best. So USG, TVS, and SIS. SIS is saline. Anybody know what is SIS? Saline insufficient sonography. Orthat, what happens? You push saline by a device, you push saline through the cervix, and you under ultrasonography and examine by ultrasonography, you see the cavity much better than normal ultrasonography. So TVS, USG, you all know, it is transabdominal USG, that is the probe is kept over the abdomen. Transvaginal, it is another probe, it is put inside the vagina. And SIS, it is also transabdominal, but saline is insufflated from below. Then come MRI. It is often asked which one is better, MRI or USG. MRI or USG more or less same, but in case of adenomyosis, MRI is far more definitive, gives far more definitive diagnosis, because sometimes it is very difficult to differentiate between fibroid and adenomyoma. Fibromyoma and adenomyoma is very difficult to diagnose. So MRI is better than USG to diagnose adenomyosis. Number four, cervical cytology, particularly in elderly women where there is possibility of hyperplasia or malignancy. There we go for pap smear. Then comes endometrial biopsy. This is also in older age group. Endometrial biopsy we can take by some when we examine for hormonal effect on the endometrium. This sampling is enough by people sampler or Sarkar curate. People sampler you haven't seen, but Sarkar curate you have seen in instrument. It is outdoor. It is an outdoor procedure. Just put the curate inside and take it out. A pinch of endometrium will come out, and you examine the tissue. You will know the nature of the hormonal status of the endometrium. But if you suspect malignancy, these two are insufficient, because you are getting a small amount of endometrium and from a particular corner of the uterus. So there D and C is far more informative. So there is dilatation and curettage. Whole endometrial cavity is curated and the whole endometrium curated out, sent for HP, histopathological examination. Or sometimes in selective cases, laparoscopy, particularly in adolescent age group. You all know endometriosis. Endometriosis is very common nowadays, and it is very difficult to diagnose endometriosis. So in endometriosis, particularly if it is associated with dysmenorrhea, which commonly occurs in young patients, their laparoscopy is indicated to diagnose endometriosis or any other pelvic pathology like any tumor in the ovary or in the uterus. So in selected cases, laparoscopy is also done. So these are the diagnostic methods. These are the procedure how we will diagnose a case of AUB. Number three, then comes management. Due to diverse etiology and occurrence in different age groups, management is planned considering all the factors: her age, her reproductive or sexual function, her severity of the bleeding, and any associated, whether there is any other associated pathology. So considering all these factors, we we decide how will you manage, whether general management is all that is necessary, or she will require some medical management, or whether she will require surgical management. So these are the three types of management. Some patients will be cured by general management, some will require medical management, and some will require surgical management. So what is general management? Rest. In any type of bleeding, when she is bleeding, rest is the rest and rest. At least for first 2 to 3 days till the bleeding stops. In any type of bleeding, rest is most essential. So she should be at rest for at least 48 hours during heavy bleeding. And sympathetic handling, particularly in adolescent age group. What happens actually, it is written in some books in that way that puberty, menorrhagia, adolescent age group, it is not the patient who requires treatment, it is the parents who require treatment. Parents become so anxious, this, having this and this, just counsel her, this is normal. It actually, what happens? In adolescent age group, her HPO axis is not developed. It takes 2 to 3 years to, as you all know, when she enters the puberty, all the endocrine glands starts activation, and the proper their coordination, it takes time to develop proper coordination amongst the glands. It takes 2 to 3 years. So during the first 2 to 3 years, since menarche, we usually do not advise any hormones, because that will ultimately hamper her normal development. So in that case, in those cases, unless there is severe bleeding, even it is written in some books that even if she requires blood transfusion, give her blood, but don't give hormone at the earlier stage, age group. So general management is rest, assurance of and sympathetic handling, correction of anemia, that is by iron, and in severe cases you can give blood, or find out for any systemic disease like thyroid deficiency or prolactin or any kidney or liver disease, you have to rule out this. Leukemia, blood, it comes within the blood. I have seen patient come with menorrhagia, on investigation she turned out to be a case of leukemia. She had no other complaint. On investigation of menorrhagia, this was the first time leukemia was diagnosed. She came with menorrhagia, a case of leukemia. Now, after general management, medical management. Medical management is broadly classified under 2 groups, that is non-hormonal drugs and hormonal drugs. Non-hormonal drugs, as I was telling, that we usually do not give hormones to adolescent age group, that is puberty age group. NSAIDs, all NSAIDs are prostaglandin synthetase inhibitors. তোমরা সবাই জানো যে prostaglandin is synthesized from arachidonic acid by cyclic dehydrogenase. This enzyme is inhibited by NSAIDs. So prostaglandin synthesis is abated, and bleeding, these drugs reduce bleeding by 25 to 50%. Mefenamic is better for older women, and in ovulatory bleeding, mefenamic acid usually given 300 to 600 mg per day. Then comes tranexamic acid. So NSAIDs are prostaglandin inhibitors. Then comes tranexamic acid, very commonly used nowadays, and it is best for IUCD bleeding, IUCD induced bleeding. It is an antifibrinolytic agent, tranexamic acid. Then comes ethamsilate. Ethamsilate, it produces capillary stability and increases platelet aggregation. Number 4, these are all the non-hormonal drugs, NSAIDs, NSAIDs, tranexamic acid, ethamsilate. Then comes hormones. Hormones are actually, there are 2 hormones, estrogen and progesterone. Estrogen can be given alone, progesterone can be given alone, or this can be given in combination, like combined contraceptive pill, COC. Estrogen, When given alone in acute bleeding, severe bleeding, injection Premarin, natural estrogen 25 microgram given IV every 4 hourly till the bleeding stops. Usually bleeding stops very quickly within 12 to 16 hours, maximum 20 hours. Heavy bleeding, give IV conjugated estrogen 4 hourly. It, as I already said, estrogen helps in proliferation of endometrium. So regeneration process is enhanced. Estrogen increases blood coagulability. So high doses of IV estrogen stops bleeding very effectively and quickly. What estrogen does? It increases proliferation of endometrium, that is the process of healing is enhanced. It enhances platelet adhesiveness, fibrinogen, factors 5 and 10 production. This all leads to coagulability. As estrogen increases blood coagulability, that is why deep vein thrombosis is common in patients taking estrogen. Then comes progesterone. Progesterone is more effective in anebular bleeding. As I already mentioned, in anebular bleeding, there is no progesterone. Unopposed estrogen causing excessive hyperplasia of the endometrium. So, in those cases, progesterone is the drug of choice. So, estrogen singly used only in acute cases of bleeding. But in other all cases, we use either progesterone or estrogen-progesterone combination. Progesterone particularly more effective in anovulatory bleeding, and in ovulatory bleeding, combination of estrogen and progesterone is more effective. In ovulatory bleeding, combination is more effective. In anovular bleeding, this only is much effective. So how progesterone is administered? Achha, how it acts? First is reduces the conversion. It reduces the conversion of more effective estrogen to less. It increases conversion of more effective estrogen to less effective. You all know estrogen has got three types of estrogen, natural estrogen occur in our body: estradiol, estriol, and estrone. Of these three, estradiol is the more active form, estrone is the second, and estriol is the less active form. So this enzyme 17 beta hydroxysteroid dehydrogenase, progesterone increases this enzyme, thereby it converts estradiol to estrone, which is 10 times less active, 10 times less potent than estradiol. So if estradiol is 100, estrone is 10, estriol is 1 potency. Then what other than converting more active estrogen to less active, it reduces estrogen receptors in endometrium. Number of estrogen receptors are reduced. Number 3, it has got some anti-mitotic activity, so it limits the growth of endometrium. Number 4, as already I said, that PGE2 alpha, PGF2 alpha and PGE2, progesterone produces this in double amounts than this. Estrogen produces these two in equal amounts, PGF2 alpha and PGE2. But in progesterone produces PGF2 alpha doubly than PGE, which is a vasodilator. So this ratio is increased in progesterone. So there is more vasoconstriction. Number 4, organized endometrial shedding up to basal layer. That is the shedding process. If it is in case of inefficient or insufficient corpus luteum, inadequate corpus luteum accent, progesterone accent is less, so it goes on shedding, the process of shedding goes on. Previously it was called irregular shedding. That is, even after completion of menstruation, she is having some bleeding for few days. Irregular ripening is just opposite. Before actual onset of menstruation, she is having spotting for 3 to 4 days before onset of menstruation. So in both these cases, corpus luteum function is important. And another, it increases the level of endothelin, which is also a good vasoconstrictor, and it causes glandular atrophy and decidualization of the endometrium. So all these factors play in controlling the heavy bleeding, in controlling heavy menstrual bleeding. So this is the mechanism of action of progesterone. So how we advise progesterone? Progesterone may be given cyclically, may be given continuously. We can give in a cyclical way without disturbing our normal menstrual cycle, and cyclically again can be given in two ways, in a short cycle or in a long cycle. In a long cycle means from 5th to 25th days. From 5th day of the menstruation to 25th day of the menstruation, we give progesterone. That is a long cycle. And in short cycle, it is given from 16th day to 25th day. That is 10 days in a month. In long cycle, we give it for 25 days. And in short cycle, we give it for 10 days. This 10 days cycle is not that effective as long cycle, but it has got certain advantages. Patients who want pregnancy, because it does not prevent ovulation and it controls bleeding. So these are the indications how and why. If she has got heavy bleeding, so we advise long cycle, and if she is suffering from moderate bleeding and she is desirous of children, so then we give this short cycle. Then comes continuous therapy. Continuous therapy we can be given both orally and injectably, by injection or by intrauterine devices. So orally, in the like long cycle, we give a break. Here we don't give break. We give for a continuous 90 days. Then we stop. Patient has a bout of menstruation. Again we repeat that cycle in that way. So orally continuous for 90 days. Injectable is continuous. Once you give it, action lasts from, according to preparation, from 1 month to 3 months. Injectable preparations. Usually DMPA is given, depomedroxyprogesterone acetate, or LNG-IUS. LNG-IUS is Mirena or progestasert, that is intrauterine device with progesterone. Its advantage is that the progesterone is released locally, it is long acting, progesterone acts locally, so side effects of progesterone are very less because it does not come into general circulation. So it has got all this advantage, and in some cases it may reduce some endometriosis and it may reduce the size of fibroid. So these are the advantages of LNG, but LNG-IUS. But the only disadvantage is it is very costly. One device costs around 4,000 to 5,000 rupees. But if you consider the period of its action, it is almost 5 years. You can keep it up to 7 years. It contains 52. Just consider, when you are giving progesterone orally, minimum dose to 5 milligram 3 to 4 times of, per day. Sometimes it is given 10 milligram 3 to 4 times daily. The daily you are giving 25 to 40 milligram of progesterone. But in LNG-IUS, only 52 milligram of progesterone is inside the IUS, and it releases only 52 microgram. It releases only 20 microgram of progesterone every day. So side effects of progesterone are much less. So these are the advantages of LNG-IUS. But before inserting this, you have to exclude any pathology, like whether she is suffering from any cancer or cervical intraepithelial neoplasia. This should be, that's why it is called, before putting this, you do a DNC. If the histopathological report is normal, you put this LNG-IUS. COC, combined oral contraceptive. As I already said, it is better than only progesterone. It is better, it is best, but it has got more side effects. It acts more on ovulatory bleeding because it suppresses the HPO axis more efficiently. Both these hormones control HPO axis more efficiently than any one of it singly. And it is better for ovulatory bleeding. Or in ovulatory bleeding, only progesterone is not sufficient in some cases. Now, some other groups of drugs are also sometimes used. These are normally routinely not used. They are used just before surgery. Patient is waiting for surgery, or patient is unfit for definitive treatment, surgery, unfit for surgery. These are the drugs. Danazol, number one. Danazol is a synthetic steroid, is derived from ethisterone. It suppresses the HPO axis. Hypothalamo-pituitary axis suppressed, a state of pseudo-menopause is achieved. So, patient has got many complaints. So, he usually given in 200 to 400 milligram per day in divided doses. It is not much used unless, as I said, the patient is waiting for surgery or she has got a huge, large fibroid, size reduction is necessary for before operation. So, number one is danazol. Number two is GnRH agonist. This is also same like danazol. It also suppresses HPO axis, produces menopause-like symptom. But its advantage is the patients who wants pregnancy, their HPO axis is well controlled with these hormones. Then comes mifepristone. Mifepristone is an antiprogesterone. It causes amenorrhea, prevents ovulation. It is given in fibroid uterus. The patients who does not want operation for fibroid or who are unfit for surgery, this is a relatively new drug, mifepristone. It is a medical treatment for fibroid uterus. Sometimes it cures fibroid completely, or sometimes even in some cases it at least reduces the size of fibroid. Number 4 is ormeloxifene, that is centroman, soily, used as saya ekhon bolche, age soily bolto. It is a selective estrogen receptor modulator. It causes amenorrhea, reduced bladder. It acts locally on the endometrium. It does not prevent ovulation, but its only contraindication is PCO. You have to keep it in mind. This drug, ormeloxifene, is a very good drug as contraceptive or in controlling bleeding in menstruation. But PCO is a common cause of abnormal bleeding. But this drug is not advised in PCO, particularly PCO. It is contraindicated in PCOS because the disease is exaggerated with ormeloxifene. Number 4, very rarely used, desmopressin. It is arginine vasopressin analog. It particularly given in von Willebrand disease and hemophilia. So these are the non-hormonal drugs. So recapitulate: treatment, number 1, non-hormonal drugs. Number 2, hormonal drugs. Hormonal drugs are estrogen and progesterone, either singly or in combination. Estrogen singly given only in acute bleeding in IV injection till the bleeding stops. And how it acts? It helps regeneration of endometrium. It increases the coagulability of blood by increasing platelet adhesiveness, increasing factor 5 and 10. So, estrogen singly, and progesterone singly is given particularly in anovulatory bleeding. It could be given cyclically, continuously. Cyclically, short cycle, long cycle, continuously, again by oral or by injection or by LNG IVs. This is the management with hormonal drugs, and some special drugs or other drugs normally not much used unless these indications like when patient is waiting for definitive treatment, surgical treatment, or for facilitation of surgery, a huge fibroid inside uterus. It is very difficult to operate. So you give a course of GnRH agonist or this mifepristone to reduce the size of the fibroid, to facilitate surgery and to decrease bleeding during surgery. So this is the medical management of AUB. Next comes the surgical management. Surgical management, as we already mentioned, the management should be decided considering her age, her reproductive function, sexual function, or associated pathology. All this should be considered. So common is D and C, but should we go for D and C in an adolescent woman? whatever amount of bleeding she is suffering from, we will never go for DNC in an unmarried woman or a girl of adolescent age. So, but DC comes first in elderly. Actually, women are divided in 3 age groups. That is before 20, 20 to 40, above 40. Before 20, we will always go for general management. If it is not controlled by general management, we will go for hormonal therapy, medical management with hormones, but never surgical management. Unless there is definite, suppose she has got a large fibroid. Normally, we will not go for any surgical treatment in adolescent group. Similarly, in elder age group, that is above 40, when there is no palpable pelvic pathology, we first treatment is first diagnostic. First thing we should do a DC. The DC will help in both in diagnosis, and DC has got some therapeutic value also. As you curating out the devitalized and necrosed endometrium, bleeding stops immediately. Faster than any drug you use to control bleeding, if you do DC, it will stop bleeding very fast. DC completed, bleeding stopped. So, DC particularly done in elderly women, not in young age group. I mentioned that it has got some therapeutic effect also. In about 25% patients, DUB, AUB is cured after DC. So, this is the advantage of DNC. Number 2, endometrial ablation. You are destroying the endometrium. How we do it? It can be done by thermal balloon, hot balloon inside uterus. You put 78 to 90 degree temperature saline inside the balloon of the catheter. Keep it for 8 to 10 minutes. 10 minutes inside. It will damage the endometrium. So, endometrium will be damaged and there will be no menstruation. So, ablation of the endometrium may be done by thermal, that is by heat, microwave, radio frequency. Now it is laser has come. Even microwave also come. Recently, microwave is also using for destroying this endometrium. Its disadvantage is patient requires endometrium easily regenerates. In 20 to 25% cases, symptoms come back. And number 2, it is a permanent method. Endometrium is destroyed. There may be Asherman syndrome, synecdoche of the uterus. Number 3, transcervical resection of endometrium. See, instrument put inside the uterus hysteroscopically, you see, and you take out the endometrium in full depth. Number 4, hysteroscopy. By hysteroscopy, you hysteroscopy is also used both for therapeutic and diagnostic approach. Patient having irregular bleeding, you go for hysterectomy. You see any abnormality in the endometrial cavity, suppose a polyp, whether it is fibroid polyp or endometrial polyp, you do polypectomy or directed biopsy. From local pathology, you can do directed biopsy. So, hysteroscopy could be done and of therapeutic value, polypectomy, mammectomy at the same sitting. Diagnosis plus treatment in the same sitting with hysteroscopy. Finally, hysterectomy. Hysterectomy is not the treatment of DUB unless there is it is intractable control arteriovenous fistula. It will acquired or congenital arteriovenous fistula. No drug will do any help to the patient. Or heavy uterus, deformed uterus, patient, elderly patient who have completed her family or who has potential chance or definite malignant case, then we go for hysterectomy. Or finally, uterine artery embolism. Uterine artery embolism, embolus is put inside the both uterine arteries, particularly large fibroid in a young age woman who wants to preserve her reproductive function. So, both the uterine arteries are embolized. So, uterine blood supply is reduced. The fibroid gradually shrinks So all these are methods of surgical management of AUV. But the final